today, like I was telling you, we are so privileged to have Mr. Wilson Mosbe here with us from Nairobi, Kenya. I'm going to let him introduce himself. Today we have someone important from Oncology, cancer treatment in Kenya. He is here for you guys to ask questions. You know, so don't come back later and say, oh, I was not there. How can I reach him? He is right here. So I'm a breast cancer thriver. People normally come here asking me to look for a shirt. I have so many shirts. In fact, I was wearing a shirt, but because I was coming live, I had to remove it by the road. Wilson, when I was talking to you, I was driving, and because I like keeping time, I had to stop the car and get ready for my live. You know, so I'm going to allow you to introduce yourself. I will not introduce you. I'll let you introduce yourself. Go ahead.
Okay. Yeah, so hi everyone. It's a joy to be here to join this show. Diana, thank you. You're doing such a great job, and it's a privilege. So, as you mentioned, my name is Wilson Mosbe, oncologist. I'm an oncology social worker. I work at Kenyatta National Hospital, which is the biggest referral hospital in East and Central Africa. I work with the Cancer Treatment Center. So this is my 8th year. I've worked with them for 8 years. Yeah, but I've worked before with Hospice, which was supporting cancer patients. I worked with them for 4 years. I also worked with the USAID, AMPAT. So basically in the cancer space, I have worked for 12 years.
Wow. Wow. Now,
Yes, so
if
that's,
you worked in the
yes.
cancer space for 12 years, what do you do as an oncology social worker? What do you do? What's
Okay, so
what's your description of your daily when you wake up, you get to KNH or you get to wherever? What do you do with the patients?
I do a lot of work with the patients. Number one is when we receive the patients, we do what we call a navigation. So patient navigation is we receive them, we break the news of cancer to them. Actually, a research was done and it was realized that in our public hospitals, the doctors don't have a structured and a good way of breaking the news. And most often they are sharp and not very careful with their wordings.
Okay.
And sometimes patients go into shock because of the abrupt news. Let me give an example. When I joined KNH at the Cancer Treatment Center, I once saw a doctor who told the patient, well, this is cancer and it is so advanced, it is at stage 4. What were you doing till it reached here? You're almost dying. And the patient went into shock actually, and it actually impacted treatment. So what I learned is we have formed a good partnership with the doctors, and nowadays they give us to break the news to the patient. Yes, so the doctors are doing a good job. They give the actual treatment, but they give us to break the news. So we sit with the patient, we take them through, and we take them stage by stage. So that's the first thing we do. Second, we take them through basic information of cancer. Yeah, personally, I've been trained by American Cancer Society. Actually, I work for ACS. I work for American Cancer Society.
That's great.
Yeah, so they are the ones who have based our team to support the KNH Cancer Treatment Center. So what we do is that we take them through basic information, what cancer is. We take them through the kind of treatment. We tell them to expect either a surgery, either chemotherapy, or a radiotherapy, or hormonal treatment. So we take them through that, and lastly, we take them through also the side effects. Once we have done that, then we journey with them. We also enroll them to support groups. So we've divided these support groups. We have a breast cancer support group, we have cervical cancer support group, we have prostate cancer. So we have divided them, and we do them at least twice a week. We have support groups. So we ensure they're in a support group so that they can share with other patients undergoing the same thing.
Okay.
So that's what we do. Plus, additionally, later on this show, I'll talk about the challenges that patients go through. But just to finish, is that we also uh, outsource for financial assistance for needy patients. So we have so many patients who are unable to pay their bills, to buy the drugs. So we partner, we do a lot of networking with non-governmental organizations and other well-wishers. So we outsource for funds to support needy patients. So basically, Diana, that's what we do on a day-to-day basis.
Wow. I never knew you guys do all these. Because you see, sometimes when you get patients and people are talking about private versus public, the mentality we have is public does not even do much. You're just left there. But I'm seeing a lot of, and American Cancer Society being one of them, you guys being there, for patients to tell them, navigate, this is how you navigate, this will be a doctor, this is where you'll be going, and then all these things. Now, when you talk about one of the things you do is you break the news to them. How does that work in coordination with the doctors? Because I believe the patient has done scanning, the patient has done a biopsy, and they are going to the doctor to give them their biopsy results. How does it happen? Does the doctor inform you before the patients come, and then you wait for the patients in the doctor's office, or how does it work?
So we formed a very good partnership with the doctors. Once they have gone through the biopsy report, that is the histology, they come with a file to me, and they take me through the medical information so that the patient is told, is brought to our offices. Then we will sit with them and take them through, hey, this is what your biopsy report says, this is what we have seen. So once we get to know their level of anticipation, and we want to know how much to establish how much they know about the cancer, so that will address how I break the news to them. So once we've taken them through the basic information of cancer, we will take them back to the doctor, who will now proceed with treatment. At least we'll have broken their ice.
Yes, yes, yes. Now, let me ask you, as you do this, is your team made up of counselors, also therapists, in case you maybe get a patient who may turn suicidal because of that news? Because patients do. I was one of them. Can you imagine?
Oh,
When I was
sorry.
told I had cancer and moving through, and I was about to start my treatment, I actually told the doctors, see, we just make this thing short. I did not know at
Mhm.
that point that I was suicidal. I thought I was giving them good news, as in this way can be easier. I told them, look, I have little children. It is not good for them to see their mother suffering like this. Inject me that thing and let me go. And immediately they contacted the chaplain for the hospital, and they contacted the therapist. And I was immediately started on those programs. The chaplain came to talk to me, and I was told I cannot start treatment until I start speaking to the therapist. And that helped me so much, to accept. The stage of acceptance was so hard for me. So do you have this kind of a department, or are you guys also trained in counseling and you provide all that?
Yes, actually, the medical social worker has been trained a lot on counseling. Yes, and we do the counseling part, especially the psychosocial aspects, we do it much deeper. The other medical aspect, the medical and clinical aspects are taken over by the oncology nurses. So they're the ones who do more of the clinical follow-up, but we deal mostly with the psychosocial.
Okay, okay, that's wonderful. That's wonderful. Now, what's the trend? I
Mhm.
know you've been there for over 10 years, because
Yes.
I am seeing the trend from the outside, and comparing here in the US and Kenya, there's a lot of cancer mortality. There is mortality everywhere, but the rate at which it is claiming Kenyans and maybe across Africa, East Africa, is higher. Why? Why is that so?
That's a good concern, Diana. One thing, there are a few things that actually contribute to this. One, I think there is still a little awareness. Still, the awareness is not much in the general population. As much as there are many groups that are now starting to come up and dealing with cancer awareness, still the gap is wide, and most people are not informed or present to the clinic, to the hospital when it's late, when it's advanced. Whereas had they been screened earlier, it would have made it, we would have arrested the cancer much earlier. So my view on the general way we can improve is one, early screening and detection. That way we will reduce the mortality by a great margin. Uh, Another thing that I feel also, especially in public hospitals generally, is sometimes the slow pace of treatment. Let me give an example. If a patient comes to a public hospital, most often they'll do a biopsy. The biopsy results may take perhaps a month and a half to come out. And when they come out, you'll find often the doctor asks the patient to do some scans. The patient may be asked to do maybe an abdominopelvic CT scan or a chest CT scan or an MRI, or nowadays they'll ask for a PET scan. Now, let me just give an example of Kenya. Is a PET scan is only found in 2 hospitals in Kenya. It's only in Aga Khan, which is a private hospital, and a PET scan costs 82,000 Kenya shillings. And the only public hospital with a PET scan is Kenyatta University Teaching and Referral Hospital. So it's not even there in KNH, which is the largest referral hospital. So unfortunately, you find patients take time to do these scans. And then once they book these scans, you'll find they queue like an MRI in public hospitals. The shortest time you can receive one is 2.5 months, up to 3 months. So you can imagine the time it takes. And all the time when that patient comes back to hospital, the doctor always tells them we can't do much without the results of the scans. So in short, what I'm saying is the procedures are quite slow in the public hospitals, and sometimes it necessitates patients to go to the private hospitals to do these scans. And unfortunately, the private hospitals are a bit expensive, and a good number of patients cannot afford the cost of the scans that is outside the public hospitals. So that's one of the challenges. I mentioned one is lack of proper awareness, which makes patients present late, no early screening. Number 2, I mentioned, is the slow pace of treatment. And number 3 is that sometimes the machines break down. To be honest, in our public hospitals, you might find perhaps the radiotherapy machine has broken down. Patients have been put on queue for perhaps another 2 months. And often it delays their treatment. It gives the cancer an opportunity to grow. So another reason is patients lack finances to pay for their medical expenses. This is a problem that I face quite common, and I think I could call it one of the leading. One thing you must note, Diana, and our viewers, is the NHIF. The NHIF is the National Hospital Insurance Fund. It's the insurance cover which is funded by the government. And as much as it helps patients, unfortunately, it doesn't pay for all the cost of treatment. So you'll find patients are unable to afford the cost. Just a good example, I mentioned about scans. You may find that an NHIF will pay for 2 scans per year annually. So you may find a doctor has given the patient to do perhaps 4 scans, maybe an MRI, which could cost Kenya shillings 28,000. That is like $280, 280 American dollars. And the NHF will tell them the policy is they'll pay for two, leaving the patient to pay for the others. So you'll find some are stuck. In fact, Diana, we always do phone call follow-ups. Whenever I call my patients, a good number will tell you, I'm so sorry, medical social worker, I haven't found money to do the scans. And the doctor told me without the results of the scan, he might not be able to help much. So this causes a lot of delay in treatment. Take another example as I finish. The patient has been, the doctor has given the patient to do radiotherapy, perhaps 33 sessions. You'll find the NHIF pays for 20 sessions. So the other remaining 13, which could cost around $500 American dollars, most patients are unable to afford.
Yeah.
So this makes them delay treatment. So my point is lack of adequate finances to pay for the cost of treatment is a big impediment to the patients. And this is why you see there's a lot of delay and patients having high mortality. And maybe one last thing is, which is a big issue, is a lack of a place to stay during treatment. This comes mostly when patients are given to do radiotherapy. Perhaps a patient has been told to do 25 sessions or 30 sessions of radiotherapy. You know that radiotherapy is done daily. It's done daily, on a daily basis. And it's in our public hospitals, it's done on outpatient basis. So most patients have to come from home. So here in Kenya, you'll find patients have come from the up country, the
Yeah.
villages, and they have no place to stay in Nairobi during treatment. Perhaps they don't have relatives. And like in our public hospitals, you'll find patients sleeping on the corridors and on the benches the entire month, which exposes them to opportunistic infections.
Yes.
So this is the state of public hospitals in Kenya. Yeah, and actually it even prompted myself and a few friends. We actually looked for a place where we rent and support patients, just to have a place where they can sleep so that they don't miss out on their treatment. So Diana, these are some of the challenges or the trends in public hospitals, which in my experience have found to be a challenge to patients.
Wow. You know, just like we've been guessing, when they come here, they tell us this, but today we are hearing it from the lips of a professional himself. You talked about PET scan costing 82,000 in Aga Khan. What of
Yes.
at KU? How much is it?
It's 45,000 shillings.
That's still a lot.
Yeah, that's like $450
Yeah,
American
that's
dollars,
quite a
yes.
lot. That's quite a lot. Now, in a case where the machines have broken down, and guys, please tap your screens. Normally we come here, professionals come, we create awareness. Somebody does not hear, then when trouble comes, they come back and ask, oh, that day that person was saying, guys, tap your screens. Now, when machines break down, especially the radiotherapy, because there's a patient actually there at KNH that we connected with, and there was a time she could not go for her session because the radiotherapy machine had broken down. Now, if it takes maybe 2 months, either for it to work or for someone to get MRI, is there anybody informing the patients that during this period the cancer is growing?
Yeah, the navigators often see to the patients and explain to them. Yeah, unfortunately, some patients may not have the chance to come back to hospital because they just call and say, I'll only come because I don't have transport. So I'll only come when the machines begin working. Yeah, so sometimes we try on our part to try and do some negotiation with the private hospitals to at least lower their rates, because obviously they are much higher than the public hospital,
Yeah.
to lower their rates and accommodate the patients whose cancers are a bit more aggressive,
Yeah.
and to try and at least save those who are in a dangerous position. So I'm so happy. Actually, I must commend Aga Khan and MP Shah, who've been so resourceful, and they've
Wow.
been assisting patients from public hospitals. Yeah,
Wow.
unfortunately, sometimes they are also quite limited. They may not be able to take the huge number. So we often forced to sit down with the doctors and prioritize, and they try to advise on the cases which are a bit more risky. So we prioritize them. Yeah, so that's what we do when the machines break down.